Good morning. I want to welcome you to the neonatal abstinence syndrome training, which another way to entitle it is working with newborns in withdrawal from being prenatally exposed to drugs. I'm Marquita Hange. I'm one of the licensing workers, and I'd like to introduce our speakers, Becky Baker and Megan Main, both of whom are licensed Anoka County providers. They both work at the Children's Minnesota Mercy Hospital campus at Level 2 NICU. Becky is a kinship provider. She has 5 children and an assortment of dogs and cats at home. And she has 25 years of experience in maternal child health and a master's degree in nursing. Megan was recently licensed as a foster to adopt provider. She has a Bachelor of Science in Nursing and has worked for 11 years in neonatology. Welcome.
Thanks. This is a topic close to my heart, and it's what Megan and I do every day at work. I would say that it's rare that we do not have a baby on our unit that is experiencing withdrawal. Sometimes in a 16-bed unit, we have had as many as 6 or 7 babies who are experiencing withdrawal, which makes it a real challenge to keep the unit quiet and focused and keep all of those babies happy. So we're going to talk today about what we do in the hospital. We're going to talk about what you can look for at home to give you some objective data, so some hard data when you're taking that baby to the doctor, to talk about how that baby's withdrawal period is going. Because even though we discharge the babies, they're not done withdrawing. They're just to a point where they are safe to go home and their symptoms are under control. So we're going to talk about some of the medications we use, why we use what we use, what you can do to help keep the baby comfortable at home. Anything else? And some problems that you might see in addition to the baby in withdrawal. So first of all, I just love to scan the room. I see lots of babies here. How many of you have taken care of or had a baby placed with you that was experiencing neonatal abstinence syndrome is the technical name for it, withdrawal? More than one? One? Excellent. These babies are a challenge, aren't they? I don't see Jessica here, but I know that Jessica recently had a placement. She's supposed to come this morning, and she made a post on Facebook that said, "I've loved my relationship with sleep for the last however many years, but I think I'm done now," when her last baby in withdrawal was placed with her. These kiddos get by on not a whole lot of sleep and challenge us as foster parents to keep ourselves together and to remember how to best care for them. Just a quick conflict of interest statement. Neither Megan nor I have any conflict of interest, have any relationship to any of the products we'll talk about today or any of the things that you'll see. So what's going on in this country? This country, as you all know, I don't need to tell you, is in the middle of a heroin epidemic. Drug overdose is the leading cause of accidental death in the United States right now. 52,000 in 2015, and that number was even higher. We know that we have seen counties, not necessarily in Minnesota, but in other places in the United States that have as many as 15 to 20 deaths in 24 hours from heroin. It's fast, it's easy to get, and it's cheap. It's becoming a suburban drug and a suburban problem. It's not just an inner city issue. In addition, the incidence of babies going through withdrawal increased from 1.2 per thousand to 7.5 per thousand in that same time frame. So like I said, we have a little unit over at Mercy for Children's, but we see a lot of babies that we are bringing through the withdrawal process. We also see a large number of moms who take prescription opioids during their pregnancy. So back pain, headaches, abdominal pain. And we have a medical system that's set up to grade our physicians by whether the patient they see is happy with them. So if that patient comes in seeking narcotics and that physician doesn't give narcotics, that patient isn't happy. Therefore, we've created a system where opioids are really easy to get from a physician. Because if I say I'm in pain and that Tylenol is not working for my pain, then you as a physician now, in order to make me happy, probably need to give me something stronger than Tylenol, or I'm not going to give you a good rating. And oh, by the way, the physician's raises are tied to their patient satisfaction in some way. So you can see how broken that system is and how easy it is to get opioids. And what we see from these women is that they are often very poorly informed about the effects of the opioids on their baby. They will come in and they will say to us, but my obstetrician told me the baby would only need to stay here for an extra day or two. And that might be true. That might be all the baby needs. But that baby also might need 6 weeks of therapy, of medication therapy, and a 6-week hospital stay to withdraw from the Vicodin or the Percocet or whatever mom was taking during her pregnancy in that opioid family. So we've got the heroin, and we've got the legal opioids that are being prescribed and the illegal opioids that they're buying off the street. Sometimes we see women who take as many as 20 tablets of something a day. That's a lot of Percocet. That's a lot of oxycodone. That's a lot of whatever drug is your drug of choice. And then we have the women who previously had a heroin or opioid addiction who are on methadone or Subutex. And those babies we know about, those babies we plan for, and we know those babies are going to spend at least 5 days with us being observed for withdrawal at a minimum, and most of them will spend between 2 weeks and 8 weeks with us, getting off of the methadone and learning to function without it. There's confusion and disagreement in the inpatient and outpatient world about how to treat these infants and how long they should be treated. How, for those of you who've had more than one infant, how old were the babies when you got them from the hospital? A week?
I was working in the hospital, so that.
You were working in the hospital, okay. So some babies come home at 5 days, some come home at 2, some come home at 40. So it makes it hard for us as providers to know where that baby is at in the withdrawal process. This is data from our state. This is data taken from the Minnesota Healthcare Program. So MA or any MA product, whether it's the Medica, the Blue Cross, all of those products that carry MA. And you can see that the green line is the rate of maternal opioid abuse. And the purple line is the rate of NAS, neonatal abstinence syndrome. So that baby is now forced to abstain from the narcotics that its mother was taking because they're no longer available because he's on the outside. And you can see the rise in both of those. And I'm going to call your attention to this little statistic in the bottom. 20% of these babies, the first diagnosis occurred at the time of delivery or in the first 2 months postpartum. I would say at least once to twice a week, we get a call from the newborn nursery about a baby who they've begun scoring. There was no history of maternal opioid use that was given by mom. There was no history documented in the medical record anywhere. And by 12 to 24 hours, 12 to 36 hours, that baby is starting to display symptoms of withdrawal. And then it's too late to get a urine specimen on the baby. We may or may not be able to collect stool, and we'll talk about all those in a minute. But now we have a baby who's exhibiting signs of neonatal abstinence syndrome with no history. So as you can imagine, that's a really fun conversation to go have with the parents. I need you to understand that these are the symptoms that your baby's displaying. These symptoms are consistent with neonatal abstinence syndrome. And often, I would say, 9 out of 10 moms will go, yep, I was taking my friend's Subutex, I was taking my friend's Percocet, I had Percocet left over from something and I've been taking it for the last month, or I've been buying it, or heroin, whatever might be their drug of choice. I would say most of them, when confronted, will be honest with us with what they were taking, because we try to frame it from we need to care for your baby and we need to give your baby the best care possible, and we can only do that if we know what we're dealing with, what medication or what street drug you've been taking that your baby's now withdrawing from. So just a quick little slide that talks about why drugs of abuse happen, because they give us pleasure. It feels good. We live in a world where it's go, 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 go. Lots of anxiety, lots of things to get done and things to do, and very little time to relax is the culture that we've created in this country. So these babies are indeed born addicted. They do not have the psychological need for the medication, but they have the physical need for the medication. They have opioid dependence. Their brain has not been able to release that norepinephrine while the opioids are on board, that chronic opioid exposure, and then when we pull it away, it's released into that norepinephrine is released, and that's where we get all of those signs that we see. So physically, it's a physical process for these babies that they have to get through in order to get the drugs out of their system. This is another slide taken from that same data on Minnesota healthcare programs, broken down by ethnicity. I don't know if you can see it. On the left is non-Hispanic Caucasian, and it works its way over non-Hispanic Black, Hispanic, Asian, and our large purple bar there is American Indian, our Native American population. There is a high incidence of NAS in our Native American population, which is generally confounded with alcohol use. And by contrast, we have very few Native American foster parents. I would say when we have a Native baby, very rarely does it actually go to a Native foster parent because there just aren't that many available to us to choose from. What's the difference between opiates and opioids? You'll hear the terms used interchangeably. Just know that one, opiates, is what occurs naturally from that poppy. Remember that line in The Wizard of Oz? Ooh, poppies will make them sleep, when she puts them in the field. And opioids are synthetically created. It's what we've created in the pharmaceutical warehouses in this nation. So if you hear those terms used interchangeably, that is the difference in them. One's naturally occurring, and one is synthetically created by us. So let's talk a little bit about the medications that you're going to see or you're going to hear about your baby being on. So the big one that you're going to see, and this is interesting because I'm going to show you data that says this is not the best drug that we should be using, is methadone. The generic name for methadone is Dolafine, and I would say you almost never hear it called that. It's almost always called methadone. It is a narcotic, but it does not produce the high that other drugs produce. And so that's why it is a choice for previous opioid addicts, because it maintains their physical need for the drug without altering their awareness or their level of consciousness. Okay? We also use morphine. Morphine we have to dose much more frequently. We have to give it every 3 to 4 hours, and it has a shorter half-life. Half-life is how long it takes a drug in your body to get to half of the level you started at. Okay? So it's something in the pharmacy world, in the medical world we use quite often, is half-life. So morphine has a shorter half-life than methadone. The other thing that we use is Subutex. Subutex is the brand name. The generic name is buprenorphine. And what that does is it's not a narcotic. It allows them to not experience the cravings or withdrawal. And Subutex is often given as a little piece of film. Have any of you ever seen the Listerine strips that you put in your mouth? That's how Subutex is often dosed. It does come in a tablet form, but it's often dosed in that little film that they put under their tongue, and it dissolves. So a quick word about Subutex and Suboxone. You might hear those. Anybody ever hear of those two things and what the difference is? Suboxone has Narcan added to it, or naloxone. Naloxone/Narcan. So naloxone is the generic name. Narcan is the brand name. If you are high and I give you Narcan, all of your high just went away just like that. So we use Subutex, which is, we use Suboxone, which is Subutex with Narcan added for moms who are at high risk of using other drugs, because the Narcan in the Suboxone keeps them from getting high. And we recently had a patient who was switched to Suboxone and was so incredibly angry that she had been switched to Suboxone. So what does that tell me as a foster parent or as a nurse or as a case manager? Probably she's using something else if she's really mad that she just got switched to Suboxone, because now she can't get high from whatever else she was using. So that's the difference between Subutex and Suboxone. And again, you might hear those terms used interchangeably, but they're not quite the same thing. The mother study. The mother study was done in 2011 by the National Institutes of Health. It showed us that infants born to mothers treated with methadone had longer hospital stays, longer treatment with medication, higher doses of morphine and methadone, and higher peak NAS scores. And we're going to talk about what the NAS score is, and actually Megan's going to spend a good part of this presentation talking about how we create an NAS score, because that's going to be the objective data that you walk away with here today, is how to score your baby. And when you go to the pediatrician, give objective data and say, you know, last week his scores were this, and this week they're this. We're on the road to getting better. On the flip side, infants whose moms were on buprenorphine had shorter hospital stays, shorter duration of treatment, lower cumulative doses of medication, so that morphine and methadone. But up to 50% were still reported to have severe withdrawal, and mothers being treated with buprenorphine were much more likely to be using alternate substances. So in the hospital world, we still see, I would say, 8 out of every 10 patients on methadone, maybe, and then the other 2 will be on Subutex. And this definitely pans out to be true, that our Subutex babies are usually in the hospital for shorter times than our methadone babies. Methamphetamines, where do they fit into all of this? Because we have a lot of methamphetamine use in this area, especially when you go north, Cambridge, Mora, big use of methamphetamine in that area. Amphetamines are a neurostimulant, so they're not in the same class as opioids at all, and they don't produce the same withdrawal symptoms that opioids do. If I give you a stimulant, and then I take your stimulant away, you don't want to eat, and you don't want to really do much of anything. You just want to sleep. Okay? We know that methamphetamine use while pregnant is associated with poor outcomes. We had some very high-profile cases, actually in Anoka County, of moms who used and were charged with harming their baby during pregnancy. But we don't have a lot of evidence about methamphetamine's long-term outcomes and how these kiddos do. Methamphetamine now sort of reminds me of the crack cocaine crisis in the late 80s, early 90s. We know how the babies act as babies, but we don't know what the long-term outcomes are for these kiddos when it's time to go to college, get a job, function in the real world. What's their interaction with the criminal justice system? Do they have a higher rate of arrest and legal problems than the general public? We do know that there is concern for behavioral problems in babies and young children who are born to methamphetamine moms, and we also know that these babies often are small in size. They're growth restricted is the term that we use, and then smaller heads. So the technical term for smaller heads is microcephaly. So in the obstetric world, when we talk about a growth restriction, we use the terms head sparing and not head sparing. Because if a baby has a small head, what's inside your head? Your brain, right? Babies generally have a head that's quite a bit larger than their bodies. So if you have a baby with a small head, you probably have a baby with some brain injury related to that drug use. We know that babies of mamas who take methamphetamines are at a significantly increased risk for cardiac, gastrointestinal, and musculoskeletal abnormalities. These babies often have physical problems when they're born. And we know that there's no medication available to help us treat these babies. Minnesota statutes, I just wanted to touch on this because we hear people say, well, what right did you have to test me? Minnesota has some very clear statutes about where we have rights to test a mother or a baby. We can test our moms if they fail to seek prenatal care, if they had less than 6 prenatal visits, if they come in with unexplained preterm delivery, unexplained really high blood pressure, cocaine if you have a mom take cocaine and come in, her blood pressure will be through the roof. And to the point that the placenta can actually shear off the uterine wall. It's called an abruption, and then you end up with an emergency delivery of a baby, however old it is. So any of those things, obstetric complications is what goes to that. Allow us to drug test the mom without her consent, and we can always drug test a baby without mom's consent if the baby is displaying signs of neonatal abstinence syndrome. Or if mom gave a report of drug use during the pregnancy. That's another thing that leads us to test babies. And anytime mom is on a methadone or Subutex, Suboxone program, we collect and test those babies also. How we test, I know some of the facilities in the area are moving toward umbilical cord testing. And the great thing about umbilical cord testing is you don't have to wait for it to occur. As soon as the baby's born, you cut a length of umbilical cord, put it in a cup, and send it to the lab that does the analysis. Right now, at Children's, we still primarily use urine and meconium, but as you might imagine, it's hard to catch baby pee. So we put little bags on them, and we try to catch it, but you really need the first pee or the second pee, and a lot of babies pee the second they're born. So there's no bag on, and so now you've already missed the first one, and that's going to be your most concentrated, the one that's going to give you your best results. But meconium, all of you know what that is? It's that thick, icky, black first stool that babies have for the first 2 or 3 days of their life. Meconium actually has the ability to go back to the 28th week of pregnancy. So we collect meconium, and our analyzer in this area is MedTox Labs. We send it to MedTox, and they send us a nice little report in about 48 hours talking about what is in the stool. The meconium analysis will not only break down, so people will say, oh, I'm positive for amphetamines because I took Sudafed. Nope, it can tell whether it's Sudafed or methamphetamines when it breaks down the toxicology. It can tell whether it was the poppies in your muffin or the morphine that you had. All of those things. So that's how we get our results. That's how we know what mom and baby were using and what baby's being affected by. Any questions? Please, please, please raise your hand if you have questions. Don't sit there and go, I don't know what that means, because I want you to be clear. And Megan and I do this every day, and we shoot these terms around every day, and sometimes they just come pouring out of our mouth without thinking that someone else might not understand what we said. How long are drugs in the system? How long can we detect it? Heroin, 24 to 48 hours after the last use, but then we see the withdrawal. Opioids, buprenorphine, remember, is that Subutex. Methadone, alcohol. In 2010, the state of Minnesota added alcohol to the mandatory screening. So that statute I showed you 2 slides ago actually tells further on the statute what we need to test for, and in 2010 we added alcohol and marijuana to that statute here in Minnesota. TCAs is tricyclic antidepressants, not so much used anymore, but there used to be a couple on the market that could kind of get you high if you overdosed them or if you crushed them and snorted them. So that's what that stands for. And SSRIs I'm going to talk about in just a minute. Where'd my SSRI slide go? There it is. So SSRIs stands for selective serotonin reuptake inhibitors. It is far and away the largest class of antidepressants that we use in this country. It's Celexa, Lexapro, Paxil, Prozac, Zoloft. How many of you know somebody that takes one of those drugs? How many of you have 3 or 4 of those in your medication cabinet? That'd be me with 6 kids. I've got the pharmacy going on, right? So this is a huge class of drugs, and we know that so often our birth moms who are using or who are clean and on a methadone and a Subutex program also have mental health concerns. And most of them are on one of these SSRIs. So when a mom is on an SSRI her whole pregnancy and doesn't decrease the dose or doesn't stop taking it in the last couple weeks prior to pregnancy, funny thing, we see some symptoms in our babies that are really similar to NAS symptoms. And sometimes it takes us a couple days to weed out, is this caused by her mental health medications or is this a drug withdrawal? Because if I have a negative tox screen and a baby that looks like this and is shaking, I have to start looking for other things that are making that baby so shaky. And often it comes down to this. These babies are kind of fun. One of the things they do is stare at you, and they don't really like to breathe when they're first born. They just like to just look at you. Takes them a while to transition into the big wide world. So I'm going to let Megan take over, and Megan's going to talk about the signs and symptoms of neonatal abstinence syndrome.
So there are a lot of symptoms that babies tend to show us that we look for when we suspect a kid is going through withdrawal. The video is actually right after this slide, so I'm just going to briefly go through this. The video will actually show you some babies who are experiencing withdrawal symptoms, and then I'll go through our scoring process a little bit more in depth. So some of the signs and symptoms we're looking for are tremors. Tremors can be mild and just have hands and feet, or tremors can be full body, arms, legs, usually rhythmic and equal on both sides, so just that shaking, constant shaking that you typically think of when you see a withdrawal kid. Irritability, increased wakefulness. They don't sleep a whole lot, not as much as a quote-unquote normal newborn. High-pitched crying, increased muscle tone, exaggerated moral reflex, and we'll get into that with the video on what we're looking for with that. Frequent yawning and sneezing, sweating, nasal stuffiness, fever, mottling, poor feeding, uncoordinated suck, excessive sucking, vomiting, diarrhea, dehydration, poor weight gain, and seizures. Not all babies withdraw the same way, and some don't show any symptoms at all, so it's just kind of a slew of symptoms that we're looking for. And the video will show you pictures of some of this stuff.
Like, I was in labor, in the bathroom shooting heroin, about to give birth to a child. A lot of people were like, how could you dare do that? How could you dare do that to your child? But nothing matters except for getting high. When I'm getting high, nothing matters. I'm very selfish, I'm self-centered.
So that baby has tremors as well.
Those are severe.
That baby's not being touched and he's still tremoring. You're not bugging him at all. Just goes through scoring a little bit how we do it in the hospital. If we know a kid's at risk, we'll start scoring at 2 hours. As soon as we see symptoms. I'll go through this much more in depth than the video does. You all have a copy of this scoring sheet. This is the tool we use in the hospital. It's called the Modified Finnegan scoring tool, and it's very widely used across different healthcare organizations. So one thing you'll notice is kiddos have a lot more crying. They are not comforted very easily, and it's very high-pitched. I'll go through this much more in depth, like I said, after the video, but also sleep much less than a typical newborn. They're not comforted easily, they don't fall asleep easily, and they're easily woken up. This demonstrates the moral reflex, and he's going to kind of show how we elicit that reflex. It's a normal reflex in babies, but when it's exaggerated, so when he dropped him, the arms went up, that's normal. When you let an infant fall just a small ways and their arms stay up for 3 to 4 seconds, they have tremors during that, that's what we're scoring on. So you can get 2 different scores for the Moro. Arms stay up for 3 to 4 seconds, and you have hand jitteriness, or they have 3 or more non-elicited, so when you're not doing something to startle that kid, they're still startling. And then it can be more severe, and they can have all of those symptoms plus clonus, which is kind of a repetitive jerking. Again, showing these tremors, and that's usually one of the first things we see in kids that we didn't expect to withdraw from something. That's the reason we start scoring. So they're always going to get scored based on moderate or severe. They're also going to get scored whether it's disturbed, we're bugging them, we're doing cares, we're changing a diaper, we're doing something like that, or undisturbed, where they're laying in their crib and they're still doing those tremors.
Hold on to him and have strength in the shoulder girdle so he doesn't just roll through my fingers. So that's good.
This one's checking for muscle tone. A lot of kids who are experiencing withdrawal symptoms will be stiff as a board. Their legs a lot of times will be in constant flexion, so their legs are always up, and if you try to stretch them out, it's very difficult to do so. They don't have much head leg, so if you hold up a typical newborn, they'll hold their head up for a couple seconds, and then it will kind of fall back. These kiddos, that won't happen. It'll be rigid all the time.
He's got a good tone. He's resisting the gravity, and I'm very interested as far as sucking. Which with this video, so there's a good in a row. Okay, it's a very good row.
So here he's going to show head leg.
All right.
So that kid has beautiful head leg. That's what a normal newborn is supposed to do. It's supposed to fall back.
Very good.
In withdrawal kids, it won't. It'll just be
Keep
stiff.
his head up for a few seconds before he tires out.
Excoriation, that typically happens from the constant movement of the baby and also from the excessive sucking at their hands and knuckles. We're going to go over myoclonic jerks. We have a couple more videos to demonstrate the difference between these and tremors. I'll talk about that a little bit more. Seizures is obviously the worst symptom of neonatal abstinence syndrome and can lead to death. So that's why we're scoring these kids, and that's why we're medicating these kids, so that they don't end up having seizures. And sometimes seizures are really hard to pick up too. Sometimes it's just involuntary sideways gaze with the eyes, whereas this one's a little bit more severe. But it's not always like you think of a seizure like full body convulsions. It's not always like that with a newborn. big thing with the seizure versus tremors. Tremors, if you put your hand on the child's body, those tremors are going to stop. With a seizure, they will not. That's how you know the kiddo is having a seizure.
In the hospital, our babies are often naked except for a gauze blanket because they are so warm.
Yawning and sneezing, although a normal thing, if they're doing it more than 3 to 4 times in your scoring interval, which is every 3 to 4 hours, that's excessive, and they would get scored for that. I love that picture.
So the sneezes can be right in a row, or they can be totally, they can be 30 minutes apart. If there's 3 or more, that can be
So tachypnea is a fast respiratory rate. So while the child is not crying, after a feed, they're calm. If their respiratory rate is still greater than 60, or if it's greater than 60 and they're using all their extra muscles and you can see a pulling in while they're breathing, they're going to get scored for that. This has to do with excessive sucking. We'll talk about that more. Often we see poor feeding with kids that are experiencing NAS. They're always wanting to suck on something, but then they get the bottle in their mouth and they're not sure what to do with it. They can't close their lips around it. They're gulping. They throw up during their feedings. If they throw up more than once, they would score for that, or if they have projectile vomiting. They also get scored for loose stools, which is very objective and sometimes hard even as nursing staff to decide, well, is that a loose stool or is that a watery stool? Because it makes a difference in their score. Watery stool is going to soak into the diaper like that one, much like urine would. And loose stool is just going to look looser than a typical newborn. Okay, and we can stop the video here. So I'm going to go over that all again in a little bit more depth. But like I said, so this modified Finnegan scoring tool is what we use, and it just goes one by one. If this, then they get a score of this. If this, they get a score of this. And then we add it all up at the end. So it starts with continuous high-pitched cry. Our purposes of going through this are so that you have a generalized idea of what we're looking for in the hospital. But also, when you're taking a kid home straight from NICU or a level 2 nursery, you're going to know, okay, so my kiddo was doing this when we left the hospital, and now they're doing this. And you're going to be able to tell, should I call the doctor for this? Wow, that would increase a score by 10 points. You're going to want to call the doctor. Maybe that kiddo needs to be put on more meds or be readmitted to the hospital. It does happen.
And children's, we don't send babies home on medication, on methadone or morphine, but some facilities do. So you may indeed be in a spot where you are taking a baby home on medication, depending on what facility they're being discharged from.
The next slide starts with continuous high-pitched cry. Do you want to change that over, Becky? Thanks. Most infants with neonatal abstinence syndrome cry more often than babies who are not experiencing withdrawal. They're uncomfortable, they hurt. They just had a lot of drugs taken away and it's painful. The cry tends to be higher pitched. They're having some neurological stuff going on, so that's the reason for the higher pitched cry. Before we look at a baby's cry, we always make sure their comfort needs are met. So have they ate? Have they been diapered? Are they swaddled if they need to be? Have they been held for a while or are you rocking them? Now that being said, we're still looking at that entire 3 to 4 hour scoring interval. So if the baby's been awake and screaming the entire time, they're gonna get scored for it. If crying is excessive, which is inconsolable for greater than 15 seconds, or if they intermittently cry for less than 5 minutes, then they would score a 2. If the cry is continuous, which is inconsolable for greater than 15 seconds, and intermittently for greater than 5 minutes, they would score a 3. Some of these kiddos will cry through their entire feeding. They're hungry, they'll take a couple gulps, and then they'll scream. And you've already done everything. You've already changed their diaper. You've already wrapped them close to you. You're holding them. You know, you've done everything to try to comfort them, and they're still screaming. As far as sleep, babies experiencing NAS have difficulty regulating their sleep state. They can't settle down to sleep for extended periods of time. And the less time a baby is able to settle for sleep, the higher the score they're gonna get. So when we look at it, we use the longest single continuous time they slept since their last feeding. So, for example, in a 3 to 4 hour time frame, the kiddo may sleep 2.5 hours, but they wake up screaming every half hour. So what we're gonna score based on is a half hour. It needs to be continuous sleep. So if they sleep more than 3 hours, you're having to wake them up for a feeding, they would get a 0. If they sleep less than 3 hours, a 1, less than 2 hours, a 2, and less than 1 hour would get a 3. Moro reflex, this is what we were talking about on the video. So it's a normal reflex for newborns. However, if it's exaggerated or greatly exaggerated, then they're gonna get a score for it. So hyperactive would be that the arms stay up for 3 to 4 seconds and they have pronounced jitteriness of the hands during or at the end of the Moro. And we know that that jitteriness, those tremors, are rhythmic and symmetric. So both hands are gonna be shaking at the same time. They're gonna get a higher score if it's markedly hyperactive, which is the arms stay up for greater than 4 seconds and they have that clonus. When we press on their feet or their wrists, it's that thumping. They're gonna score for tremors. We've talked a lot about tremors. When baby is sleeping or at rest, so when we walk into a room to do our cares, which, you know, we'll do vital signs and then we'll change the baby, feed the baby, things like that. When we walk in and we look over to that crib and you can see that baby is tremoring, those would be undisturbed tremors. Once we unwrap the baby or start changing a diaper, anything like that, when we have our hands on that baby, those are disturbed. So,
They score both if they have both. They get points for both.
right. And so mild tremors when disturbed is gonna get your lowest score, whereas moderate or severe when undisturbed is gonna get your highest. Mild is considered just hands and feet. Moderate is considered full arms and legs. And obviously, most kids that are going through withdrawal are gonna have some tremors, so obviously they're gonna be worse when you bug them. But If a kid's doing this all the time, they're going to get a much higher score. Increased muscle tone, this is where we were talking about that head leg. Also that the arms and legs stay in constant flexion. So a lot of times you'll see kids that are like this. We try to do, some range of motion, pull those arms down, and they're just tight. Same thing with the legs. So a baby with normal muscle tone would get a 0, and a baby with increased tone would get a 2. Excoriation, that's those reddened areas. They sometimes look like scrapes or rough areas on the chin, the nose, knees and elbows. The knees and elbows is from the constant movement, those tremors, that shaking is, against any type of crib bedding or clothing, that's going to cause some irritation. The chin and nose is typically because they're always trying to suck on anything that they can get in their mouth. So that includes hands and fists, and they'll often get blisters on their hands too from all that sucking. So if we see that, we score a 1. However, we only do that the first time it's seen. So if I see it the next time and it hasn't got any worse, there's not a new area, they don't get scored for that again. So myoclonic jerks can be a little bit more serious, kind of leading up to a seizure sometimes. So they do get a little bit higher score, but they're different than tremors in that they're a lot of times quick jerks. They're not rhythmic. They're not symmetrical. So both arms aren't doing it at the same time, or both legs aren't doing it at the same time. Anytime we see them, they get scored a 3. And we're going to show you the difference. So this is a myoclonic jerk. It's not both sides of the body. It's not rhythmic at all. It's not continuous. Sometimes it'll just be, 2 or 3.
Yeah, get a hand now. Foot's doing it now as well.
And
often these will last. You will end up taking a baby home who may be having myoclonic jerks.
And they kind of weird you out when they happen, because they do look a little bit like a seizure.
Like tremors, myoclonic jerks, when you hold the extremity down, they're going to stop. A seizure, when you hold the extremities down, will not stop. This is a tremor. Tends to be a little bit more rhythmic and symmetrical, so both sides of the body are going to be doing it at the same time. Okay, so seizures, like I said before, one of the most concerning signs we see as caregivers, and one of the most things you should be concerned about as caregivers after taking a baby home. Seizure is always an emergency. It's always a 911 call. You're always getting that kiddo in as fast as you can. And the reason for that is because a seizure can lead to death. So definitely the most concerning part of this whole neonatal abstinence syndrome. They are usually rhythmic movements, so they'll be pretty consistent, but they can't be stopped by placing your hand on the child. Sometimes they're just an eye deviation, staring off to one side. Or they can be lip smacking or chewing in a rhythmic way where they're really hard to catch sometimes, but a lot of times, like with the eye deviation, they'll have lip smacking with it. Or they'll have one of the other, some of the movements with it.
And you can't get their attention. You can't break that by, cooing to them or talking to them.
And a seizure can last anywhere from, 15 seconds to until you get them to the ER. So, all right, the next group of things oh, actually not. Sweating is by itself. So when assessing a baby for sweating, we're looking at their forehead and their upper lip. Kiddos that are going through withdrawal tend to be hot. Their metabolism is on overdrive. They're moving all the time with these tremors. So we have to be really careful that these kids aren't overbundled. You don't need a big warm sleeper on a withdrawal kid. More than often than not, they're gonna need a t-shirt and a diaper. Sometimes a lightweight sleep sack. We'll get more into that in a little bit. But we always make sure that we're not overbundling. That's not what's causing the sweating. Usually with that, we'll see kind of full body sweating, back of the neck, and on their clothing. Whereas with neonatal abstinence syndrome, we're gonna see it more on the face, forehead or upper lip. So they would get a 1 if there's sweating noted. And then we look at hyperthermia. So like I said, these kiddos, their metabolism's in overdrive, they're moving all the time, so they're gonna be hot. Their muscles are constantly working. So we assess temperatures by taking an axillary temperature under their armpit. If it is, that should be 100.4 to 101. That's gonna score a 1. And they would get a 2 for a temp greater than 101. And I would say probably 90% of the kiddos we see have elevated temperatures.
The other thing we do is keep their rooms cool. Sometimes we have to have the thermostat down around 67, 68 for these kiddos in order to keep their temp within an acceptable range. And like I said, often they're naked if they're really having trouble with temp.
Often in cotton too, where it's gonna kind of pull that temp, it's gonna keep the moisture away, things like that. Did you have a question?
Yeah. If they're spending so many calories on all this extra stuff, they must not gain weight very easily.
Right, and we'll get more into that. So her question was, do they have problems gaining weight because they're spending so many calories? Their metabolism is so high, and we will get into that because they definitely eat more than a typical newborn does, and burn way more calories. All right, some additional signs of NAS that we look for with each assessment is that frequent yawning, so more than 3 to 4 yawns in that scoring period. Sometimes that's hard to assess. So for nursing staff, we're not with that kiddo for that whole 3 to 4 hours. We're with them during their feeding and their cares, and then if they settle down long enough, we go on to the next baby we have to care for. This is something you guys can help with a lot if you're visiting the infant in the NICU. Telling us about yawning and sneezing, because sometimes we miss it, and we do the best we can with that. Modeling, you'll see on this little picture of the arm here that kind of pink and white marbled look to the skin. Has to do with that metabolic rate and them trying to pull the blood into their vital organs. So it takes it away from the extremities. But often you'll see modeling on their full body, their chest also. Nasal stuffiness, they're gonna get a score for. Obviously, you're gonna try to clear that. So if you have a bulb syringe, they're gonna get really mad, but you're gonna try to clear out that nasal stuffiness if possible. If they have a really bad cold, if you can hear them coughing and other upper respiratory stuff, we're not gonna score for nasal stuffiness. So there are some exceptions to this that you have to take into consideration. Sneezing more than 3 to 4 times in that scoring period. And nasal flaring, on the video, it briefly showed it. Most of us, when we breathe, we don't use our full nostrils. If their nostrils, every time they take a breath, they're getting bigger, that's going to be nasal flaring, and they'd get a 2 for that. Tachypnea or rapid respirations. A normal respiratory rate in a newborn is 30 to 60 breaths per minute. If they're breathing over that, they're going to get scored a 1. If they're breathing over that and they're using all of these muscles, you can see on the picture he's pulling in with his abdominal muscles. You'll often see it under their rib cage, using all those extra muscles to pull in, then they're going to score a 2. We always try to make sure the kiddo's comforted and fed before we take a respiratory rate, because if he's mad and crying, of course it's going to be elevated. But a lot of times these kiddos have an increased respiratory rate even while sleeping. Excessive sucking.
Don't go anywhere without a pacifier with an NAS baby.
Pacifiers will be your best friend. These babies will often suck on anything that they can get in their mouths, and not just when they're hungry. So this one can be a little difficult because babies have normal rooting behaviors where they're out, when they're hungry, they're looking for something to suck on. They'll suck on their pacifier. They'll suck on their hands to show you they're hungry. This is all the time. This is anytime they're awake. It doesn't matter if they just ate 3 ounces. They just have that drive to want to suck on something. And oftentimes can't get it together enough to really suck on that pacifier. You'll have the pacifier in their mouth and they're just looking all over for it, like can't figure out that it's right there and that they should be sucking on that. This is also where those blisters on their hands and knuckles and the excoriation around their mouth can come from. So they would get a 1 if they have excessive sucking. Poor feedings. So we talked about this a little bit with the bottle. They can't quite get their mouth around that nipple. They have an uncoordinated suck and swallow pattern. And they gulp while they're eating. Some of them scream through a feeding. They're just not very coordinated, even though they end up eating a lot. It's taking greater than 20 minutes. And they're, a lot of times, they'll make a couple sucks and then forget. It's almost like they forgot what they were doing. Like, okay, I'm going to cry because I'm still hungry, but I don't realize the bottle's in my mouth. So just very uncoordinated. And this can lead to some of the weight problems that we see in these kiddos too, which we'll get into. Vomiting. So in addition to the poor feeding, these kiddos can vomit a lot, which leads to the dehydration, leads to the weight loss, leads to the failure to thrive. So if a kiddo throws up the whole feed, which it always looks like more when a kid vomits than it is. If you were to actually take like 3 ounces of milk and pour it out on a burp rig, that would be saturated. It would be dripping wet all over onto the floor. So we rarely see a kid regurgitate their whole feeding. But if they're throwing up 2 or more times during a feeding, then they're going to get scored as well. This is not associated with burping. So if they have a spit right after a burp, we're not going to count that. All kids do that. A lot of kids do that. And then they're going to get a 3 for projectile vomiting. So if I'm sitting here bottling a baby and Becky's sitting there and the kid throws up and it hits her leg, that's projectile vomiting. Very forceful. And that typically is going to be a full feeding. Loose stools is a huge problem for these kids. Diaper rash is a huge, huge issue. Their butt is constantly wet from these loose stools. And some of them are just so watery and so irritating to their little butts. We'll talk about kind of what you can do to help that out when I talk about ways to comfort these kids. So the way we differentiate for scoring between loose stools and watery stools is if the stool is half liquid and half solid, so some of it's sinking into the diaper, but there's definitely still some solid stool on top of the diaper, that would score a 2. It's looser than a typical newborn stool. A typical newborn stool shouldn't sink into the diaper. It shouldn't be that loose. It should stay on top for the most part. They're gonna get a 3 if the whole thing's in the diaper, just like urine. So you can tell by the color of it, it's obviously not urine, but there's nothing on that top layer of diaper.
So are you getting a picture of these babies? They don't sleep a lot. They do eat a lot. Takes a long time to feed them. They want their pacifier all the time. And they're just generally not happy-go-lucky, relaxed kids. These kids spend a lot of their day balled up, their little hands and feet tight, their faces in a grimace. They're not your smiling 6-week-old who is having a little trouble today. So when do we start treating a baby? Because we want our babies to be comfortable. You don't want to take home a baby who's so miserable that he can't sleep. And that's what I hope that you walk away from this learning with today, is the ability to say, you know, I picked this baby up at the hospital 2 days ago and it didn't have tremors, or it only had mild tremors when I disturbed him. And today he has tremors all the time and he's only sleeping for an hour after he eats. Those are all objective things that a physician will go, oh yeah, that doesn't sound good. You know, so your choices are, you go to a physician's office, you can go to the doctor's office, or you go to the emergency room if you really think your baby is in that bad of a state. If you have a baby that you can't calm or is having tons of tremors, because those babies are at risk for seizure, and it does happen. So a lot of facilities start treatment when they have 2 scores greater than 8. And I was thinking that was our protocol, but then this morning I went, I think it's 1 score of 12 that we start them.
It changes so frequently.
Yes. So, you know, we look at the guidelines, we look at our outcomes data all the time, we look at how long our babies stay, what are their scores, but our goal is to keep their score below an 8. That's always our goal.
On how old they are.
Right.
Because a 6-week-old is going to be awake more than a newborn.
So you'll have to adjust a little bit just by using your own knowledge, because you know that it's normal for a 6-week-old to be awake for 3 hours during the day, to have a couple stretches while they're awake. It's not normal for a 6-week-old to be up 3/4 of the night and then most of the day too. And that is something that we do see. So if we know that a mom has used opioids or is on a methadone program or on a Subutex program, those babies stay with us for 5 days. They get scored every 3 hours during those 5 days. And if at any point they exhibit enough symptoms, have a high enough score, we start them on medication. And once you're on the medication road, you're pretty much committed to at least a 2-week stay with us, because it takes a while to wean. Because once we put you on, we don't just take you off. We take you off very gradually. So we start with a particular dose, usually around 0.5 milligram of methadone. And then we go up from there until your symptoms are controlled. Once your symptoms are controlled, we leave them alone for a day or 2, and then we start the wean. So ideally, in the perfect world, we wean the dose by 10% every single day. In the real world, often our babies don't tolerate a wean, and it may take 2 to 3 days for their scores to get back down to a spot where they can wean again. So if they have 2 scores above 8 in a day, they don't get to wean the next day. And it's hard because these moms and dads often have multiple social problems. We're trying to teach them to care for their baby. Sometimes dad's incarcerated, sometimes mom's incarcerated, sometimes grandma's caring for the baby. We see all manner of things. We see moms who are in mandatory treatment, who 24 hours after the birth are going back to the Metro Treatment Facility or whatever locked facility they came from when they came to give birth. So we see all manner of things and lots of social problems. But if you know that you as a foster parent are going to be taking this baby home, we invite you in from the moment you know that you are going to have custody of this baby at discharge, because the longer you have to get to know this baby's quirks, to get to know their sleep patterns and all those other things and what that particular baby's symptoms are, because these babies run the gamut. We see moms who come in on very high doses of methadone and their babies have minimal signs of withdrawal, and we see the opposite, moms who are on little doses and it takes us forever to get those babies off of methadone. I think the longest I've seen since I've been there is a baby that was with us about 10 weeks. And you can imagine, I mean, we have private rooms for our babies, but 10 weeks in a 10 by 12 room is a long time to be hanging out with us. One of the nurse practitioners and I often joke that we're going to open our own little house for these moms and babies to live at, where we can teach parenting and do everything that needs to be done to get the social house and the social life in order to support that baby. Because a high number of these babies do go out to foster care, and a high number of them end up not going back. So weaning can take anywhere from 2 to 8 weeks. There are no givens in this process. Every single baby is different. Like I said, it's not dose dependent. Mom could have been on a ton, and you can get that baby out the door in just a few days. Mom could have been on a little, and your baby is with us for 6 to 7 weeks. And then once we get down to where we turn the medication off or we stop giving that methadone or morphine, the baby has to stay with us for 48 to 72 hours to make sure that they're not going to get into trouble. And then every once in a while, we get a baby who around 48 hours, we end up giving them what we call a rescue dose. And that's just another dose of methadone. So now that our 48-hour clock starts all over again. And I forgot to talk about, when we were talking about medications, there are a couple of what we call adjunct medications, so additional medications that we use for these kiddos if they're still having trouble. One of them is phenobarbital. And that's something you may be very likely to see as a foster parent, is a baby who's discharged on phenobarbital. If we have babies who really aren't sleeping but don't have a lot of other symptomology going on, they often will use phenobarb for these kids to help them to get control of those tremors and the sleeping, and it works quite well. Something we don't see as much in this country, but lots in Canada, is clonidine, and if any of you have kids with ADD, you often see clonidine used for them also. Clonidine, guanfacine, kind of all in the same family, and actually they're all blood pressure drugs. It was their original creation, but they have some nice neurological side effects that are very calming. So you may see babies on either of those medications in an attempt to help them. Breastfeeding, feeding breast milk, what's the recommendation? We know from lots of studies that there's really poor correlation between the maternal dose of methadone and the amount of methadone that crosses into mom's breast milk. And what the American Academy of Pediatrics says is adequately nourished narcotic-dependent mothers can be encouraged to breastfeed if they are enrolled in a supervised methadone maintenance program and have negative screening for HIV and illicit drugs. So their drug screen came back clean except for the methadone. They're adequately nourished. We want them to breastfeed. And here's the reason, because that baby just gets that additional little dose of methadone that's pretty constant into their system via the breast milk. And so if we have a mom who went back to the treatment center, we try to negotiate with the treatment center. How often can she come? How often can you bring her breast milk? We teach her to pump before she leaves. If you can get breast milk from your bio mom, do it and meter it out. So maybe she's only able to pump 10 ounces of breast milk a day. Give 2 ounces at each feeding so that you spread it out through the day. Because we get in trouble when we get into situations where all of a sudden mom either disappears from the treatment center or discharges and disappears, and she's been providing us with lots of great breast milk, and all of a sudden we have to switch to formula. Those kiddos are miserable. We generally end up having to increase their medication dose, and we take several steps backwards if all of a sudden we don't have any breast milk. Even if they're on an MA product and they have transportation problems, they can usually get the insurance company to pay for a cab once a day for them to come to the hospital, and and they don't have to just come and go. They can come and stay for 3 hours, and then the cab will come and pick them up and take them home. So yeah, we very highly value breast milk for our NAS babies. Any questions? No? All right, Megan's going to take over and she's going to talk about how do you comfort these babies. And this is my favorite thing. We say this all the time in the special care nursery. We say, this is going to be a baby that gets worn when it goes home. Because that's the only way those kiddos are happy. Baby wearing.
All right, so this is what you're gonna need to know if you take one of these kids home. What can I do to make this a little bit easier on both of us? And things that you'll see us do in the hospital too if you're visiting a baby in the NICU. Keep the baby's surroundings quiet and calm. Low lights, turning off the TV, turning off your cell phone or setting it to a really low ring. All of those extra noises and stimulation are gonna cause this baby to have more withdrawal symptoms than they already have. Touching and moving the baby gently and slowly, no sudden movements, just being very quiet and gentle. Using a soft, low voice, keeping visitors to a minimum. So if you're visiting one of these kids in the NICU, you typically aren't gonna wanna take, your 5 bio kids with you. That's not a good environment for these NAS kids while they're withdrawing and while they're weaning off their meds. It's too much stimulation, too much noise, too much going on. Letting the baby sleep. So only waking him or her up for feedings if for some reason they're not waking up on their own. That doesn't typically happen. But letting them sleep when they can and for as long as they can. A lot of these kids, so most kids in a neonatal nursery of any type are feeding every 3 hours. These kids, because of the volumes of food they take at a time, they will a lot of times allow them to go 4 to 5 hours because we know they don't sleep much. So if they do happen to get a chunk of 4 to 5 hours, we want them to have it. And we kind of already talked about caring for the baby without a lot of handling or touching and trying to schedule care around feeding times. So changing that diaper, during feeding times. Obviously, if they have a blowout in the middle, you're gonna have to change their diaper, but doing as minimal interruptions to their sleep as possible. Other ways you can comfort a baby with NAS, don't overbundle. We talked about using a cotton t-shirt, diaper.
Have you all seen these gauze blankets that are very popular right now? This is what we use. We actually issue 3 of these to every baby who is in our care with a diagnosis of NAS. And we hand wash them and draft when they get dirty.
That being said, in the foster care setting, you cannot bundle a baby in a gauze blanket unless they are awake and you are there with them. It is against the safe sleep rules, which we'll go into. But oftentimes, you will end up seeing kids in our nurseries with these blankets, and a lot of times you'll end up getting sent home with them. So just something to keep in mind. You cannot do it while they're sleeping. You want to hold the infant firmly and close to the body. If you're able to do skin to skin, or if biomom's able to do skin to skin, we encourage that as much as possible. So getting the baby down to a diaper, a caregiver taking off their shirt, putting the baby right next to their skin with a light blanket over the top. Holding the infant upright and rocking with smooth, slow up and down movements. You don't want to be doing a lot of kind of hopping around and patting, gentle rubbing, slow, steady movements. Holding the baby with his or her arms close to the chest or mouth. That position is comfortable for them. The only thing you have to keep in mind is fingernails. They're going to be scratching at their face a lot with that frantic sucking. So a lot of times you're going to need to use mittens on their hands or tuck their hands into their shirt, but still allowing them to have that positioning is going to be a comfort measure for them. So I'm going to go into the safe sleep stuff now. And on the bottom of your slide, it said use lightweight gauze blankets. We changed that this morning because after reading through this little clause again. After reading through this, even with parental consent, you cannot put a baby to sleep with a gauze blanket.
Now, if they have a doctor's order, can they swaddle for the first 6 weeks?
I believe there's doctor's orders on certain types of swaddling.
Okay.
And some of these kids, that may be necessary because they may not sleep, period, if they are not in some way swaddled. According to the statute on reduction of risk of SIDS in licensed programs, so all of us, the baby has to be on their back to sleep. If the baby falls asleep in your arms, you want to get them to their crib as soon as you're able. Firm mattress, fitted sheet, nothing else in the crib, baby and pacifier. That is it. And this last part, placing a swaddled infant down to sleep in a licensed setting is not recommended for an infant of any age and is prohibited once an infant starts rolling over. With written parental consent, which we'll show you the consent form next, you can use a lightweight sleep sack, they're called, for these kiddos. So a lot of times at the hospital, we'll end up sending parents home with, it's called Halo brand. They make lightweight where it just zips up over the baby. So oftentimes just a diaper underneath them for these kids, zips up. Their arms are kind of, it's like a little tank top. And then they have wings. And the wings swaddle the baby. But due to the way they're manufactured, unlike a blanket, these kiddos can't get them in front of their mouth. And it decreases the risk of SIDS versus a blanket. So the next slide is actually a copy of the parental consent form you have to have. Parental consent for swaddling an infant, and that would be with a sleep sack only. One other thing I want to mention about safe sleep, according to the Academy of Pediatrics, you're always putting that kiddo on their back. Never, ever, ever putting a kid in any other positioning on a firm sleep surface. So if you do use a swing or anything in your home, once that kiddo falls asleep, you need to move them to a safe sleep environment. They also recommend room sharing without beds sharing.
Those are sleep sacks. So see the wings?
These ones are typically the ones that are going to work better for withdrawal kiddos because they still swaddle. A lot of them don't have arms, and that's going to be no different than just putting them in an outfit.
So if you are purchasing a lightweight one for a baby with NAS and you have parental consent, you do want the ones with the wings on them so that you can wrap them around and put their hands up by their mouth like that.
A little bit more about with the American Academy of Pediatrics. So the room sharing without bed sharing, co-sleeping is never recommended. It just increases the risk of SIDS a ton. Routine immunizations, so not always possible in our world, but that does reduce the risk of SIDS. Using a pacifier is huge. They say that can decrease the risk of sudden infant death syndrome by 50%.
You've got it covered with your NAS babies. They'll gladly take it.
Right. Breastfeeding also does decrease the risk. So, in the hospital, if mom is still able to give milk, if she's in some sort of program and is not on any other illicit drugs other than like methadone or Subutex, that decreases the risk. And avoiding soft bedding, overheating, and exposure to tobacco smoke, alcohol, and illicit drugs. So overheating with any kid, not just these NAS kids, but you don't want to overheat any kid. If you're comfortable in your home in, long sleeves and pants, your infant should be comfortable in your home in a nice warm sleeper. You're going to be able to tell if they're too hot. You can feel them, feel their chest. If they're too hot, decrease the blankets or not blankets, decrease the amount of clothing. And again, with the sleep sacks, as soon as an infant starts to roll over, you have to stop using them. They get tangled, they can't move right, it affects development, it also increases the risk for SIDS. All right, some more ways we can comfort these kiddos that have neonatal abstinence syndrome. Soothing the infant. Infant massage is sometimes very helpful with these kids, and ECFE often has baby massage classes, so something to check out. Relaxation baths. A lot of withdrawal kids like baths, and a lot of them need more baths than a typical newborn. So we usually tell parents that are going home with a typical newborn, don't bathe your kiddo more than 2 to 3 times a week. NAS kids sweat, they're hot, they're moving all the time, and sometimes they need their skin cleaned more than that. They're gonna have oilier skin because they are sweating all the time. So more frequent baths is sometimes really helpful. Using a swing to soothe the infant. So in the nurseries, you'll see what's called a mamaroo. All of our rooms at Mercy have one, and they are very helpful. So unlike at home, in the nursery, we can let kids sleep in these because we've got them hooked up to 1 million monitors that's going to tell us if something happens. But at home, stuff like that can still be useful to calm the infant and then move them to a safe sleep environment.
The mamaroos are very rhythmic, and they have several different settings. They can move in kind of a circle. They can move straight up and down.
And you can even set them up to your iPhone now to do like the sound machine, the waves and the heartbeat and all of those soothing rhythmic sounds too.
We issue a sound machine with the 3 blankets. So our NAS kits for our babies have hats with earmuffs included, have sound machines, and have emery boards for their nails and their blankets.
So we do recommend using a sound machine or a box fan. Sometimes just the noise of the box fan, so pointing it towards the wall, but just that steady hum will kind of decrease stimulation and drown out some of the other noises that might be going on in your house. We talked a little bit about baby wearing. Sometimes these kids need to be held all the time, and you're gonna have to figure out a way to get your other stuff done while you're holding these kids all the time. Because the second you put them down, they'll be awake. And then some miscellaneous things, changing the diaper frequently. So we talked about how loose their stools are and how caustic that is to their little butts. We use just a clear barrier cream. There's an example of it in this picture. It's not a Desitin, it's a clear ointment that you just put on with every diaper change, and that just protects their skin. It's not for if they already have a really bad diaper rash, their butt's really red. It's to prevent that.
Yes, ma'am.
Vaseline works really well.
It does work well.
Yes, Vaseline does.
And this is similar. It's a clear, just gel. It's not thick white paste like Desitin. You don't want to use Desitin as a preventative because it doesn't allow the skin to breathe. That's for if the skin is already red and already broken down. Frequent diaper changes may be necessary because they are stooling all the time and it is this loose stool. Using mittens, like I said, and keeping fingernails short with a nail file. Like Becky said, we have emery boards in our kits that we give to parents because they're constantly at their face and end up with a lot of scratches and excoriation from that. Making sure their clothing and bedding is clean and dry. These kiddos are moving, these kiddos are sweating. So you don't want them to sit in those wet t-shirts, those wet sheets. Having spare sheets on the bed all the time might be necessary because they might be soaking through them. Feeding on demand. So anytime these kids want to eat, they should be fed. You don't need to worry about them eating too much. These kids eat a ton, probably 2 to 3 times more than a typical newborn. And that is because of their increased metabolic needs. They're moving all the time. They're at risk for dehydration. They're at risk for weight loss. They will eat a lot. Some kids, while they're still in the hospital, actually need higher calorie formula because they just can't keep up and they keep losing weight. And these kids are at a really high risk for failure to thrive, which would end up being a readmission to the hospital. One thing that you can do to make sure these kids are getting enough to eat, even if you're like, you ate 4 ounces, I know you had enough to eat. Because of how much they're pooping, because of all their movement, it might not be enough for them. So keeping track of weights, either on your own, you step on the scale with your infant, you step on the scale without your infant, just to have a general idea, and keeping track of wet diapers. Because even though they're taking a lot in, they're losing so much fluid through stool, through sweating, through movement, evaporation. Wet diapers is going to be your first indicator of dehydration, and dehydration is fast in infants. So if you're not getting your 6 to 8 wet diapers a day, you need to be calling that pediatrician. And that's when we talk about when to call the doctor. When should you be concerned? We kind of talked about if you're noticing some of those scoring things that, wow, that's a lot worse. But it's just some general things of why you're going to call on top of just normal things you would call about with a newborn. Crying that lasts longer than 3 hours and isn't helped by comfort measures. You've done everything. You've fed, you've burped, you've rocked, you've changed diapers, you've everything. You've been holding this kiddo, rubbing their back, everything, and they will not stop crying. They need to sleep. It's going to be important. So if they're going over 3 hours, call the pediatrician. Intense jerking of the arms and legs, even when you try to gently hold them still, could be a seizure. That would be a 911. Don't call your pediatrician, call 911. Vomiting or diarrhea that's more than occasional. So if you're like, wow, this just got so much worse, that's going to be a reason to call. Poor feeding. If this kiddo had been taking 3 to 4 ounces and all of a sudden they're only able to take, a ½ ounce to 1 ounce, that's going to be an indicator that something's going on and they're just not getting it together enough to finish their feeding. If they have no dirty diapers in a 24-hour period or fewer than, I always say 6 to 8, because by the time they go home, they're after that 4th day of life. Most NAS kids are not going home before 4 days, so 6 to 8 wet diapers a day, really important. Something else about calling the doctor. Most of the pediatricians, especially in Anoka County, are not very familiar with treating neonatal abstinence kids. So if you do have a kiddo that goes home on phenobarbital, they don't have that experience managing those meds. A lot of times you're going to end up having to take them either down to the U to a children's clinic or to Children's Minneapolis to their outpatient clinic because they don't see it enough. They don't have to manage it enough. They see a lot of kids after that are off meds, but you may have to find a specialty doctor because our pediatricians up here just don't see it enough.
If they need medication therapy, they are automatically transferred into the special care nursery and into the neonatologist. The neonatologists just deal with sick, early babies with other needs.
And I know a lot of foster parents struggle to find a good doctor that has experience with this. Because honestly, 10 years ago, we weren't really catching it as often. Not to say these kids weren't withdrawing, but we weren't seeing it in the hospital as much as we do now. So they're starting to get better. I'm going to talk about some outcomes for these kids. What happens later in life? So some outcomes for infants who are going through withdrawal. A lot of times these kids are premature. They're stressed out in utero and they end up coming early. A lot of them have low birth weight. A lot end up with failure to thrive, as we talked about. Some of them have delayed physical growth due to the prematurity, low birth weight, and increased caloric needs. Congenital anomalies, depending on mom's drug of choice, it does affect different systems as they're developing in the womb. So it can end up with a whole slew of problems at birth. Defects in regulation, quality of movement, and excitability. We talked about those symptoms. Well, after having those symptoms for so long, it does affect development and the way that they regulate after those symptoms are gone. Some motor delays, such as sitting independently and crawling, and these kids have an increased risk of SIDS. That being said, some of the increased risk is due to unsafe sleep habits, because when these kids fall asleep, you just want them to sleep. And poor social conditions of a lot of moms that do end up going home with their babies end up putting them at increased risk as well. As far as when they get to be toddlers, there's some speech and language deficits, short attention span, poor social engagement, and problems with coordination and balance. We're seeing with school-age kids poor sentence structure, limited vocabulary, impaired attention span, impaired language and learning skills, behavioral problems, memory problems, and impaired executive functioning. So making decisions is very difficult for some of these kids, and it varies so widely because there's so many things that these kids are withdrawing from. And a lot of times it's polysubstance abuse. So mom was on 5 different drugs. So there are some other factors that can affect outcomes. Genetic differences that characterize women who use drugs and alcohol during pregnancy. Some social factors like nutrition, postnatal environment, so whether this kid's going home to a questionable social environment or whether they're going into foster care and have some trauma issues, social class and ethnic group, polydrug exposure prenatally and postnatally, so if they're going back into that same environment and getting exposed again, that can affect outcomes. And some of the experimental characteristics when they do these studies to look at outcomes, the sample selection they're taking it from, the research design, and so forth.
And these are hard kids to follow, because if they went to an unstable biohome, it may be very hard to get any follow-up data on them or to get them back to a clinic to collect data and follow up.
Because of all of this, there's very, very limited research on any of the kids that we treat. I think I found one article about high school kids. One. Outcomes vary greatly depending on the number and type of substances used. A kiddo who has, for instance, fetal alcohol syndrome is going to be much different than a kid who was exposed to methamphetamine. They're going to have different symptoms, they're going to have different outcomes.
But often they're exposed to both, because if they're using polysubstances, they're most likely drinking too.
Results of the studies have been inconsistent. So depending on the sample size, where they're looking, the moms who do come forward and bring their kids in to continue the study, things like that. That's supposed to be inconsistent, not consistent.
That's wrong.
And outcomes vary according to the care and interventions received after discharge. If you end up with a kid that was a NAS baby, starting with ECFE early, starting with as many, services as you can, they've shown that these kids will have difficulty, even long after the withdrawal period. The withdrawal period, typically you'll see withdrawal symptoms for up to 4 to 6 months of age. But then sometimes the irritability and stuff up to a year. After that is when we don't know what's going to happen, and the earlier we can start with some of these problems we see with school and attention and language and learning and everything else, the better it's going to be for these kids. So we are going to open it up to questions, which you guys have not had many today. Anything you can think of.
Can I clarify about the breast milk? So we've had moms bring in breast milk and water bottles. Mm-hmm. But I know that some of the moms aren't in a treatment center. Mm-hmm. Do you still want us to feed them?
I would say you're going to have to use your own judgment.
The question was, if mom is not in a treatment program, do you still use breast milk that she brings in? And Becky was in the process of answering that one. Get this thing up. There you go.
I'm going to say that's really your judgment call, and I would meet with your social worker, because your social worker probably knows whether they suspect mom is still using. And the social worker can generally get the medical records from the hospital. So if there was methadone or any other drug involved, mom probably had a toxicology screen that was sent out to MedTox, so it's very accurate, done during her hospitalization when she delivered. And see if you can get those medical records. The container doesn't matter so much. If it's clean, it's okay. I mean, it's really going to be a judgment call with your mom. What do you think your mom is doing? Because we have that trouble in the hospital too. Sometimes we have moms that come in and are fairly obviously impaired when they arrive to visit their baby. So then we have to make that judgment call. Do we now hold breast milk for a couple of days based on mom's appearance?
But usually moms that are allowed to supply breast milk to our foster kids are being screened somewhat regularly. If they're in any type of program, they are being drug screened on a regular basis.
Right. If they're in a methadone program, they either go daily to get their methadone and get screened randomly, or sometimes they go once a week and they get a week's worth of methadone. But if they're getting a week's worth, they usually have to be screened every single week when they go to pick up their methadone.
Other questions?
I just want to clarify, like, for babies, on any type of drug that they're withdrawing from, do you always give methadone? Maybe I missed that.
No, only if it's opiates or heroin.
Nothing for meth.
Nothing.
So kids that are withdrawing from methamphetamine, I think that is one of the biggest confusions about maternal drug use. They do not withdraw. They do not have the typical withdrawal symptoms that we think of when we think of a baby that's withdrawing. They're not the screamers, typically.
They're the sleepers.
They're the sleepers. They're the one with the really poor feedings. Like, not only are they not coordinated to eat, they're just not taking any volume either because they're sleeping. It's hard to wake them up for feedings. Totally opposite of what you think of when you think of like a typical withdrawal kid. And we do not treat methamphetamine at all. We monitor for other problems like the feeding stuff. And a lot of times those kiddos will stay in the hospital for 4 to 5 days just until we get the toxicology screen back, because chances are if they're using methamphetamine, they're probably using something else too. And depending, so We use methadone more often than not. However, occasionally we use morphine, and it totally depends on the drug. Now, if we get these surprise kids that all of a sudden start showing withdrawal symptoms, and mom doesn't admit to what she was using, and maybe we missed that first couple urines, and didn't collect the meconium in time because they didn't start withdrawing till day 3 or 4, we have a really hard time treating these kids because you have to treat based on what mom was on. So some of those kids will end up on like phenobarbital because we have to control the symptoms. We don't want these kids to seize, but we can't really give methadone if we don't know what the kid's withdrawing from. And everything acts so differently. And now there's new drugs that come out every day that we don't even screen for.
Yeah.
You know?
A lot of the designer drugs that are out there now, we don't even have screens available for in the hospital setting.
We only recently came up with a test for the Suboxone or Subutex. They only recently added that to like the standard panel.
Right.
We used to have to add it separately if we knew a mom was on it, and it was getting missed a lot. And we're seeing a lot of illegal Subutex use too.
I took my friends.
I personally have had 2 moms that, walk in the room, say, we're scoring your kid for withdrawal because of the symptoms they're exhibiting. And finally, after, they see their kids getting worse and worse, and they're not sleeping, and they're screaming all the time, we'll finally get the breakdown where they start bawling and telling us that, yeah, I was buying it, or I was using my friends for the entire pregnancy. And depending on whether they can, stop and stay clean off it or not, because it's illegal if it's not prescribed for you. That's what's going to depend whether these kids go home with that mom or not. Both cases that I've seen, they have, because, mom was just...
They agree to their assessment. They
right.
agree to
They're working with the social workers
recommendations.
and stopping the Subutex or Suboxone or methadone. Methadone's a big one to buy off the street too. Yep.
After talking to several other foster parents, we've been kind of collecting, we've noticed that a lot of our little ones who will come from NAS, those babies, they have a lot of breathing problems. We're noticing a lot of them getting nebulizers, all those types of things. And we've kind of noticed it's kind of a pattern
Yep.
that we've been talking to our pediatricians
So methamphetamine you're seeing that with? Or,
that and methadone and stuff.
very interesting.
Nebulizers and all that stuff. It comes around, we've seen it like about 6 months and older work that continue on.
And methamphetamine is definitely where we see more disorders and more congenital anomalies in our babies. So routinely we screen for PCP, heroin, cocaine, marijuana, alcohol, methadone, Subutex, amphetamine. I'm forgetting something though, because there's 9 of them, and I can't think of what did I say? I said cocaine. So, and opioids.
Yeah. And then once a screen is positive, it breaks it down, and a lot of times can tell us what exactly, which drug. So an opioid, is it morphine? Is it Percocet? Is it heroin? Is it what exactly is it? Because it does make a difference with treatment.
So like I said, ask for the medical records for your babes so that when you are getting continuing care for them and a pediatrician, you can say, this is exactly what this baby was exposed to. And, if that's a child that's going to an adoptive home, those records might be invaluable when they're doing an FAS workup at the age of 5 and that screen was positive for alcohol. She asked what would the indication be for morphine instead of methadone. Some babies just respond better to one than the other, and I think when we are looking at opiate addictions, we tend to use morphine more. A lot of our methadone use is moms who are on methadone maintenance, and we know about them and we're expecting them.
I think sometimes too, it also depends on the length of use. So if we have a mom who has been on Percocet for a month or 2, A lot of times they'll give morphine. It's easier to wean off. It's got a shorter half-life than methadone. We have to give it more often because it's easier, because it comes out of the body faster. So if that kiddo wasn't exposed the entire pregnancy, sometimes the physicians will choose to do morphine. We give more methadone, I think, but it's starting to turn away from that a little bit depending on the length and the drug of choice. And we don't use phenobarbital a whole lot, but some of these kids, once we get them weaned down to a very, very, very low dose of like methadone or morphine, they just do not tolerate coming off. And we need an alternative to be able to send these kids home. You know, we don't want to keep these kids till kindergarten. We want them to develop appropriately. So sometimes we do have to look at alternatives to treatment.
Well, I think Marquita, you sent out an email thing from, was it up on Calf Lake or up in the reservation up there? Where they would send home, there's such a huge
Yes, in Bemidji.
babies that the foster parents were giving them meds.
Right, and sometimes that does happen. The question was about an email that said, you know, are we sending kids home with meds? Some healthcare institutions do that, and Children's has really moved away from that, so we don't typically see that anymore, but it does depend on the situation. It totally depends. I think part of the reason Children's as a group moved away from it is because if these kids are being sent home, so if mom's on a methadone program and you're sending this kid home on methadone, how can you guarantee that that kid is getting the methadone? Huge issue. It turned into a huge issue. So we only send kids home on phenobarbital now, but a lot of other institutions do send meds home with foster parents.
And it's exactly what you said. If Bemidji kept every baby that was NAS, they would probably need to build a whole new unit. They'd need that little house I want to build for these moms and babies, because these babies do have an extraordinary length of stay. The report that I showed graphs from earlier in this presentation went on to talk about cost of these babies, and it's very high. When you're talking about a 60-day stay in a higher level of care nursery, you're talking about just the room and board costing $3,000 a day before you ever give that infant any medication or treatment. These are expensive babies. They're millions. Some of them are going to be $1 million babies before they ever are discharged if they were born prematurely too.
And 80% of these kids are on state-funded programs.
How many of these babies does a nurse watch in these little rooms?
So we at Children's typically have 3 babies in an assignment. We try not to give more than 1 baby with NAS to 1 nurse because they take time. They take love and attention. And if mom is incarcerated or mom is at a program where she's on a locked unit and doesn't get to come very often, these babies may not have visitors. And so that's why I would really encourage you as foster parents, if you know you're getting this baby as a placement, please start coming as soon as you know. It'll help you get to know that baby. It'll help the nursing staff because you'll be there to hold. And it'll help that baby stay calm and have a better outcome because they do have somebody to love on them and hold them and, you know,
That
just be
definitely
there.
decreases length of stay. When we see parents who stay, you know, some of our parents of withdrawal kids stay we have rooms that parents can stay in, that you can sleep there. And they are there all the time holding and giving that baby exactly what comfort needs, you know, they need. That makes a huge difference with how they wean off their meds and their length of stay in the hospital.
Because if you're meeting their needs, their scores are lower, therefore we get to wean every single day, and they get out faster.
Honestly, the longest kids that I've seen in the hospital are those that there's a no contact order for parents and foster arrangements have not been made yet. So the second we see that there's a foster mom coming, we get so excited. So we're like, yes, he's going to do so much better. Yes, we do.
Do you see a lot of moms who do a couple hits of marijuana right before they're going to deliver, thinking this is
I have. I've had patients tell me they only medicate with what grows from the ground. And a lot of them don't realize that THC is reportable in Minnesota.
And beyond that, so the video didn't end up having sound, but that first where you could kind of see the mom while we were trying to figure out the sound, she said, I shot up in the bathroom while I was in labor. Shot up heroin. So it does,
We had
it
a
happens
patient
all the
recently
time.
Who was shooting up her whole stay with us, and she was currently enrolled in a program. Drugs are powerful stuff. You guys all know that. Any other questions? You guys were a great audience.
Thank
This
you
is the
guys so
first
much
time
for
we did
coming.
this, so it's always a little learning.